Profesor Steve Badylak jest szefem McGowan Institute for Regenerative Medicine Uniwersytetu w Pittsburgu, gdzie mam przyjemność być członkiem fakulty naukowego i razem prowadzimy badania nad regeneracją. Cel tych badań jest poznanie mechanizmów, które regulują regenerację z użyciem macierzy pozakomórkowych, czyli Extracellular Matrix.
We've been working for 25 or 30 years now in the use of biologic materials to promote a different type of healing in patients. These materials are made of extracellular matrix. Now, the extracellular matrix, or ECM, is everything that's between all of the cells in our body. So every tissue in our body has ECM. And what we've been able to do is isolate just the matrix, leave the cells behind, and show that the signals that are contained within the extracellular matrix promote a regenerative type of wound healing in patients.
Jest dla nas niezwykłym zaszczytem możliwość goszczenia pana profesora Stefana Badylaka w Polsce, ponieważ jest to jedna z nielicznych osób, które mają związki rodzinne z Polską, a jednocześnie odniosła ogromny sukces w nauce nie tylko amerykańskiej, ale i światowej. Ja wierzę, że ta idea, którą zaczęliśmy w 2015 roku, organizując międzynarodowe sympozjum dotyczące medycyny translacyjnej, dzisiaj zaowocuje już realizowanym Centrum Medycyny Regeneracyjnej, które stanie się podstawą do nawiązania jeszcze bliższych i bardzo konkretnych współprac naukowych z Instytutem kierowanym przez pana profesora Badylaka i Uniwersytetem w Pittsburgu.
Na przełomie wieku okazało się, że komórki macierzyste są obecne i niezbędne w dorosłym organizmie. Że jest bardzo wiele różnych komórek macierzystych, one mają bardzo wiele mechanizmów regulacyjnych. Człowiek jest właściwie magazynem i części zamiennych w utajeniu i mechanizmów naprawczych, ale również tych destrukcyjnych, to znaczy potencjalnych komórek, które przekształcą się w nowotwór. Nad tym wszystkim próbujemy zapanować, właśnie poznając mechanizmy regulacyjne, sygnały międzykomórkowe, to o czym mówił Steve, czyli bardzo znacząca rola tej istoty, którą produkują komórki, która nie jest komórkami, a jest ich domem i rusztowaniem, w których żyją.
Thank you for in the invitation. And I'd like to make this as informal as possible. So if you do not understand something that I'm saying, just raise your hand or speak up or whatever, because it's important that for the later parts that you understand what's going on early. And I kind of reversed things today. I thought, because I knew I would be talking to a lot of clinicians, that we would start with the clinical aspects of this. And everything that you're going to hear this morning, and all of the work that goes on in the laboratory that I'm at the University of Pittsburgh, is based upon a couple of assumptions. One is that the extracellular matrix, which we'll talk about a little bit, is basically Mother Nature's version of the ideal microenvironment for cells, and that biologic scaffold materials that are composed of matrix have potent signaling properties, especially immunomodulatory properties. And also, the composition of the extracellular matrix is very similar between species, which is one of the main reasons that we can take pig extracellular matrix, put it in people, and not have any problems. So we'll talk a little bit more about these as we go along. I want to give you results of two studies we've done first, and then explain why they seem to these patients have done so well. The first is volumetric muscle loss. So this is something that I know you deal with at least to some extent. It's caused by traumatic injury, usually losing significant amounts of a particular muscle mass, and you know that your outcomes are going to be marginal at best. The best you can hope for is to get scar tissue and to save the limb usually. The patients that we had in this study had all been prior, had 4.5 years earlier was the average time from the injury to our surgery. The average patient had over 10 surgical procedures. They had lost 2/3 of the muscle mass of a particular group, and everything else that they had tried. So here's this study. We had 13 patients. They ranged in age from 18 to 70. These are the types of causes of their injury. You know, about a third to half of these patients were, as we expanded the study, ended up being military, like roadside bombs. Got them because this study was funded by the Defense Department. 55 months between injury and implantation, 2/3 of the tissue. And the key was that when, obviously with this long of a time, there was a lot of scar tissue. So that we went in, we would take down all the scar tissue, get to fresh tissue, and implant the scaffold. And in this case, so this is a piece of pig's urinary bladder extracellular matrix. So this is pig extracellular matrix, and it's just a sheet. It's not designed to fill the volume of what was missing. The idea is that it initiates a type of a healing response that would not occur normally. And I'll show you why that occurs in just a second. And in this, we followed them with biopsies. We took MRIs or CTs depending upon the individual lesion. In this particular case of this image, this happens to be porcine dermis that was used. We used 3 different types of biologic scaffold materials in this study. All of them, though, represent the entire extracellular matrix. A lot of times you'll see the word biologic scaffold used for collagen type materials or hyaluronic acid or whatever. Those are separate. What we're talking about today is the entire extracellular matrix. So we take a tissue, we decellularize it so there's no cells left, and what remains is the extracellular matrix. And as the biopsies, you can see, so this is 6 weeks after implantation. This is a Masson stain, so the red represents new skeletal muscle that's forming. So stem cells from the patient are being drawn into the scaffold because as the scaffold degrades, it releases signaling molecules that recruit your body's own stem cells. So in a way, it's stem cell therapy, but we call it endogenous stem cell therapy. And then there's a little bit more that occurs by 3 months, and by 6 months we get out to about that much. And that's all that will happen, because by now the entire scaffold is gone, and what the defect is left with is an area that now has some new muscle tissue. In these patients, we averaged about 40% replacement of the muscle that was missing. Now that's not perfect, but it's brand new muscle that wouldn't have occurred at all. And more importantly, were the functional benefits that these patients had. And we were able to document with the biopsies that indeed it is, these are Desmond positive cells, and that we monitored force, range of motion, functional improvement. And as you can see, we had about 37% increase in force, strength, their ability to use whatever limb it was, upper limb, lower limb. Range of motion increased as well, about 27%, and a huge increase in functional improvement. Because you can imagine every one of these patients had a different deficit. These injuries are all different. So in each patient, we would bring them in and we would identify what they could not do, and we worked on those. There's 2 keys to this study. The first was when the patients came in, we put them into a very focused physical therapy that was designed specifically for them, because like I said, everybody had a little different injury. And we worked them very hard, 3 to 5 times a week until they maxed out. And every single patient got a little bit better, because they'd been 4.5 years. A lot of them were not even doing physical therapy anymore. And we wanted them to get as good as they could before surgery, so that somebody wouldn't say, well, okay, you just started doing the right physical therapy now. So we put them in there, got them to their maximum, then we did the surgery, and then we started therapy after. So these values are what happened after the surgical procedure. The second thing is, so you can imagine that with that patient that you just saw, his entire upper, the portion of his lower limb was, proximal lower limb was opened up. We started him into aggressive physical therapy 24 hours after surgery. not just passive range of motion, actually loading him against resistance. And the reason for this is that as the cells infiltrate the scaffold, they're looking for direction as to what should I turn into and how should I line up. And if there's a force that's applied, they line up according to that force. They realize that they're supposed to become contractile cells rather than adipose cells. And so the environment and the mechanical loading, the physical therapy, is critical for success. If we put them in a cast or we just do passive range of motion, most of the new tissue would be very weak, fatty type tissue rather than active, functional skeletal muscle tissue. So we've now treated more than 20 patients. We've gotten the same results on all of them. And I was just telling Ulla that we're actually starting a second trial this week. We're starting to recruit patients, and they can come from anywhere around the world. So if you end up with one of these types of patients, and they will qualify, and I'm happy to talk to you about the inclusion criteria, we would consider it, and we would pay for, the study would pay for the entire treatment for the patients. So we can talk more about that later. So I'm going to give you a different type of a clinical application because the principles that this type of healing is based upon apply across all tissues. It's not specific for skeletal muscle tissue. And that's what we're going to spend the second half of this lecture talking about, are the mechanisms by which these events happen. On the right is a polyp, a colonic polyp, and on the left is Barrett's esophagus. How many in here have gastric reflux? No, but raise your hands. I know there's people in here who've got gastric reflux. I've got gastric reflux, but it's got to be about, yes. All right, and there's probably a fourth of you. If you're average, anywhere from 25 to 35% of you have some sort of gastroesophageal reflux disease or GERD. And that's a known step in the progression to esophageal cancer, which is the type of cancer that is increasing at a rate faster than any other type of cancer in the world, U.S. and the world today, for reasons that are pretty interesting. So if this is, an abnormal, a metaplastic, changed esophageal mucosa, why don't we do what we do with colonic polyps, which is we would go in, take it out, because we know a colonic polyp has a higher incidence of turning into cancer than a colon without polyps. So why don't we just go in and scrape away the abnormal mucosa?
Big of an area?
Pardon me? There.
Big of an area?
Well, yeah, what would happen if we did? It is a big area.
Scarring.
Pardon? Huh?
Scarring would
Yeah,
And it would eventually turn back into metaplastic after.
It would, but also the healing response would be one in which there's scarring. And with scarring in the esophagus, you get stricture. So at this point in the disease, the treatment's worse than the disease itself. So you can't go in, and so we'll put patients on omeprazole. It's really a horrible disease. The treatment is esophagectomy once it gets to the point of turning into adenocarcinoma. And this is the gold standard. We have a 7 to 20% mortality rate, 50% morbidity rate. 1 out of every 2 patients has a problem. They either, the anastomosis leaks or it's strictures, or you get hemorrhage or you get infection. And this is the best we can do. That's horrible. Frankly, the bar is low for being able to improve this type of a disease, the treatment for this type of disease. And obviously, once they remove the esophagus, they take what's left of the stomach, tubularize it, pull it through the chest, and anastomose it to what's left of the esophagus in the cervical region. So the quality of life is not very good. And this video, unfortunately, is not going to work because I didn't load up the video. But what it shows is a method that we developed with a colleague of mine at the University of Pittsburgh. His name's Blair Jobe. And Dr. Jobe is one of these people who's always willing to try things, a little bit on the edge. So what we do is go down to with an endoscope, go down to the gastroesophageal junction, and we incise all the way through the mucosa, down to the muscle layer, and we come upstream to proximal to where the lesions are, do the same thing, 360 degrees through the mucosa, and then we make tunnels at 2 o'clock, 6 o'clock, and 10 o'clock, go back down to the gastroesophageal junction, grab it, and pull the entire mucosa out. So it's like taking the sock your sock off inside out, and it's a pretty cool video. It's too bad it's not going to work. But then the entire mucosa of the esophagus comes out through the oral cavity, and now you've got this huge piece of tissue there. Now that will stricture every single time. I mean, if taking a little bit of Barrett's away would stricture, you can imagine what completely denuding the esophagus for 10 to 13 centimeters would do. And yet that's what happens. And let's see if we can get this to advance. There we go. Then once the denuded esophagus is present, we take a piece of extracellular matrix, and in this case, this is what's called small intestinal submucosa, or SIS. There's probably about 80 commercially available FDA-approved products on the market, and they come from all different types of tissue. This was the very first one that was on the market. It was developed in our lab about 25 years ago, and it only came in sheets. So what Blair Jobe did was wrap it around a balloon, went back down into the esophagus, blew it up, and wallpapered the inside of the esophageal lining, and it had to put a stent in so we could hold it there. Otherwise, it would, go downstream once the patient swallowed. And we had to leave the stent in for anywhere from 1 to 2 weeks and then take it out. And we left them in a little too long in our first patients. So this is after stripping the mucosa. This is the stent holding that piece of extracellular matrix in place. This is right after we took it out, and you can see the matrix is gone. The scaffold material has already been absorbed into the wall. It's been degraded and absorbed, and we disrupted what was the healing response. This is 5 weeks, 10 months, 13 months. And we've now done 14 patients. We published the first 5, and these are the results of the first 5 patients. All of them had advanced their disease to what's called T1A adenocarcinoma. It was confined to the mucosa. It had not gone deeper. So when we stripped out the mucosa, we took away all of the cancer. This is the new mucosa that developed, that replaced the biologic scaffold material. And it's not perfect, but it's a normal squamous epithelium. But if you notice, there's no glands. And these special stains simply show that they have the right type of basilar stem cells, and they have the right type of differentiated cells at the surface. And this has happened in all 14 patients now. And our follow-up on these patients has been anywhere from 18 months to 10 years. No recurrence of cancer. They have normal. And the best thing about it is that this is the second patient that we did. And that's Dr. Jobe, obviously, on the left. This is the day after surgery. So in the esophagectomy, they're normally in the hospital from anywhere from 11 to 13 days, huge bill, and all the complications I told you about earlier. So this patient can go home, he can eat normally. We take the stent out. Mind you, I'm standing right in your way, aren't I? So what we have done is change the way the body heals, just like we did in the muscle area. So the idea is, even though you can call it a scaffold, it's not meant to be what you think of as with synthetic scaffolds, where it has mechanical properties, holds things together, you sew it in, and you expect it to act like a ventral hernia repair. This is different. This type of a biologic material is meant to change the way the patient heals. So how does it do that? So that's what we've really spent the last 15, 20 years trying to figure out. Because in this particular case, our whole research has been kind of backwards. We first showed that it worked, then we're trying to figure out how, rather than the other way around, where you say, I've got an idea, I think this might work, you work your way up and eventually do a clinical trial. We did it the other way around. Now, so this is, I'm going to get a little bit of a biology lesson here, so bear with me. So this is the extracellular matrix. This is the normal interface between a cell and the extracellular matrix in a tissue. Now, the extracellular matrix at the top has been decellularized, but the reason I show you that picture is because to show you how intimately these things are associated. So where does the extracellular matrix come from? Anybody?
Cells?
The cells. Cells make the extracellular matrix. So every tissue, the cells in every tissue make their own matrix. And obviously they're going to make a matrix that is suitable to them. So it differs a little bit between tissues. And it's the secreted products of the cells of every single tissue. And if you'd have asked anybody in the field 25 years ago, what's the primary function of the matrix, most people would have said, well, it holds things together, it provides strength, it provides form, and talked almost exclusively about the mechanical and physical properties of the matrix, and not really mention the biologic properties. Whereas now, it's almost just the opposite. Most people recognize that the matrix is loaded, absolutely loaded with signaling molecules, growth factors and glycosaminoglycans to hold water. It's got a tremendous amount of biology. We can isolate the extracellular matrix by removing the cells, but that's not that easy to do because there's a higher magnification. And these pictures are the courtesy of Bob Meacham. He's a wonderful guy who's been in the field of matrix biology for about 50 years. And he's not a clinician, he's simply interested in extracellular matrix. But look how intimately the matrix is involved with the cell. So when you try to remove the cells, it's virtually impossible to get rid of all of the cellular remnants because some of it's going to remain adherent to this matrix. And we use things like enzymes like proteases, we use detergents when necessary, we use a lot of rinsing and so forth. Because if we don't get rid of the cells, it's like putting injured tissue into a patient. Because injured tissue is what? You injure the cells die, they release things that cause inflammation, and they lead to scarring. So the more thoroughly one can decellularize the tissue, the better the resulting product is going to be. And most of the companies that manufacture these on the market don't really appreciate that the way that they should. And this concept this of dynamic reciprocity was popularized by these two individuals, particularly Mina Bissell. And that means that the cell secretes the matrix, and then the matrix has certain properties that change all the time. Your conditions change, your nutrition changes, mechanical load, you lift weights, and so the matrix signals back to the cell and it makes a different matrix, so it's constantly turning over. So in one hand, it's like the ideal biomaterial. It's constantly changing and responding to the conditions within the environment. That's why in the skeletal muscle study, the physical therapy afterwards was so important. We had to provide an environment that informed the cells that were coming into it that this is a mechanically loaded, contractile sort of an environment, and those signals went to the cells that came. So I put this slide in, Thomas, because of our discussion last night. I'm going to put all three of them up here. Let me back up as well. Normally, I would spend about 10 minutes on this slide, but the idea is that everything on the left was an acellular, xenogeneic, in other words, animal origin scaffold material that came from different areas, the urinary bladder, the small intestine, and they were put into three different locations, the Achilles tendon, the temporal mandibular joint cartilage, and the skeletal muscle of the abdominal wall. And in every single case, after about 2 weeks, we biopsied, and it's loaded with mononuclear cells. And if you send this to the pathology lab, every single time it will come back and say, this is inflammation. These are all macrophages. We've got chronic inflammation, and yet we know that chronic inflammation would lead to scar tissue formation. That's the way we heal. We're adults, mammals that don't regenerate many of our tissues, so the normal expected response is scarring. And yet in each case, this turned into a normal appearing tendon, this turned into a normal appearing temporal mandibular joint fibrocartilage, and in this case we got, just like in the study I showed you, islands of new skeletal muscle formed. We didn't get 2 layers of internal and external abdominal oblique, but we got new muscle forming. So why did that happen? Why didn't these cells that are supposed to be inflammatory cells turn into scar tissue? And so That's the question that really drove a lot of the studies that we subsequently did. So we've done these studies now. I can't even tell you how many animal studies we've done over the past 25 years. And now we've done several clinical studies, and there are literally over 10 million human patients who've been implanted with these porcine-derived matrix materials for a variety of applications: dura mater replacement, abdominal wall muscle replacement, urinary bladder replacement, and now we're getting into the GI tract. And in every single case, the animal and the humans, when we get a good outcome, the following things happen. Number one, the scaffold degrades and goes away. So what you put in there is meant to go away. If it doesn't go away, it's treated like any other foreign material. The body responds to it and tries to either encapsulate it or somehow wall it off from the rest of the tissue. And that's not the type of response that we're looking for. We get modulation of the immune response, and we're going to spend more time on that. We get recruitment of endogenous stem cells, and we have a site-appropriate microenvironmental niche. So these things happen every single time. So this is, this recruitment of stem cells is pretty cool because stem cells are all over our body, right? And the body must have signals that say, okay, it's time to wake up, time to move over here, time to turn into the right type of tissue. And so instead of supplying cells, we're supplying the signals that reside within the matrix that say, it's time, we need you over here, wake up, proliferate, differentiate, and turn into the right type of tissue. That obviously happens, but these two events are really closely related, the innate immune response and the stem cell stuff. So I'm a physician. I learned the same things you did in medical school. We talked about this at dinner last night. Where do macrophages come from? Anybody? Come on, you guys are smart people. Where? Where do macrophages come from? Don't be afraid. I'm going to call on people unless somebody says something.
Originally,
Yeah.
bone marrow.
Bone marrow. And they circulate in the blood,
Monocytes.
called a monocyte, and then it turns into, goes out of the circulation of tissue. We call it a macrophage. Yeah. And macrophages I learned that they are phagocytes that clean up cellular debris. They help participate in recruitment of fibroblasts, and we get deposition of collagen and scar tissue that's there. And this was their job. And occasionally they would coalesce and form a multinucleate giant cell. And that was, and they were end-stage cells. Once they differentiated, there was no going back. And then about 20 years ago, the people that work in immunology said, tumors are surrounded by macrophages and lymphocytes. Why do they continue to grow? And what they found is that the tumors secrete molecules that make the cells permissive. Instead of them being destructive type cells, they became friendly, if you will. And then they started realizing that this happens naturally during wound healing as well. So everything on the left here, I've been trying to think of a better way to present this than this slide, but I haven't been able to do that yet. The macrophage gets activated by lots of different things: dead cells, injured tissue, endotoxin, and turns into these seek and destroy cells. They secrete a bunch of inflammatory mediators that you could spend your life just trying to memorize the letters and the words. The same cell, though, if it's activated by other signaling molecules, turns into a cell that looks identical, just like those examples I showed you, but secretes a whole different profile of signaling molecules that tells the body anti-inflammation. It's actually an anti-inflammatory cell. So a macrophage is an anti-inflammatory cell. And it's not one or the other. It actually is a spectrum. So they can go from the pro-inflammatory to the anti-inflammatory state. And lymphocytes, T lymphocytes, can do the same thing. Now this is amazing because macrophages they're discovered in 1901. Medycyny identified these phagocytes. For 100 years, we have one idea of the way macrophages work. And then pretty soon someone says, oh, maybe there's something more to it. And what it turns out is that depending upon the environment and the signaling molecules that are present, these macrophages take on these different phenotypes. Now, how many in this room were aware of this, at least vaguely? They're called M1 and M2. Yes, you were, because you've been hanging out with me too long.
Since yesterday.
Yeah, since yesterday. So it's not unusual that, you know, they don't teach these. The only time I'm starting to get positive responses in the audience is when there's, you know, young residents who are just coming out. They're starting to teach us a little bit in medical school. So this is really interesting, because now there are several things that, especially for musculoskeletal healing, that have now become well established. And if you get into the biology of it, after you get muscle injury, the first thing that happens right away in the first day or so is you get the typical neutrophil response, PMNs. And then the macrophages come in, and they're all the pro-inflammatory phenotype. And this happens after surgery too. You make a surgical incision, this is normal wound healing. But then somewhere around day 3 to 5, these M1 cells, the pro-inflammatory macrophages, transition. The same cells become that M2 anti-inflammatory phenotype. And this guy, James Tidball at UCLA, really discovered this and has characterized it really well. And if this doesn't happen, you get no healing and because skeletal muscle can regenerate a little bit, right? I mean, it's volumetric muscle loss where it doesn't regenerate. And if you inhibit either the M1 or the M2, you get no healing. So nobody knew this up until about 10 years ago, when Tidball applied this to the skeletal muscle. And then, since then, I just put this up to show you, literally in every body system, the same events occur. Central nervous system, GI tract, you name it. This whole pro-inflammatory to anti-inflammatory switch has to occur. You know, when you think about it, that makes sense, because if it doesn't occur, we'd have nothing but continuous chronic inflammation. And in fact, people that work in areas like inflammatory bowel disease, Crohn's disease, ulcerative colitis, non-healing ulcers, even multiple sclerosis and immune-mediated diseases now, are really intent on in investigating this dysfunctional switch from the M1 to the M2. It's stuck in the M1 phase, and it explains a lot of the diseases that are there. So this is not just related to a particular field, it's all over the place. So in the late 90s, when we had developed that first extracellular matrix material, the first application, first patient was treated for rotator cuff repair. And we went to the FDA, and we were fully expecting them to ask us, well, how can you expect to take a pig-derived matrix material, put it into a human, and not have a problem? So we did a lot of work ahead of time anticipating. Now, interestingly, the FDA never asked that question before they approved the device. I think I know why, but it was interesting that they never did. But I worked with a guy named Dennis Metzger, here's the senior author on these two papers we published, where what we did was, he's an immunologist. I said, help me understand, when we expose human macrophages or any macrophage to a foreign extracellular matrix, what happens? And at that time, the tumor guys had just come out with this M1, M2, Th1, Th2 paradigm. And it turned out that every single time we put the extracellular matrix in contact with the T cells or the macrophages, they went to the M2, Th2 phenotype. And since it wasn't a really well-developed theory yet, not well expected, we really didn't know what to make out of it. But one question I asked was, okay, if it's turning over to an anti-inflammatory phenotype, are we setting the patients up for infection? Because, you know, does an anti-inflammatory phenotype means that it can't fight off bugs or whatever? So we took animals that were exposed to this and switched over to the M2, Th2 phenotype and exposed them to things like inactivated influenza virus and other sorts of antigens, and showed that no, they could fight them off just as well. So it doesn't mean that they're not effective protectors of their job. It's just that their wound healing capacity is different. So we then said, okay, now this was about 2004 or 5. does this work when you guys put in a lot of biomaterials? You put in bones and plates and screws and anchors and lots of things. They're all foreign materials, and now there's a lot of biologic scaffold materials out there too. So we took about 15 or 20 different materials that were on the market, and we used an animal model, and we established criteria to say, is this a good outcome or a bad outcome? And they were scored by 5 separate people that looked at it and didn't know what they were looking at. So there was a totally blinded study, and they scored them. And this is what it looked like 2 weeks after implantation, and here's what it looked like 35 days after implantation. And if a lot of these names may not mean much to you since you don't use these materials, but this matched very well the clinical use of these materials. These guys at this end, hardly anybody used because they gave a bad tissue response. And the reasons for these had to do with things like chemical cross-linking of the matrix to make them stronger, but now they wouldn't degrade. And these guys over here were used a lot. And then we took the same slides and we put special stains on them and said, okay, during this remodeling event, were the cells M1 or M2? And we established a ratio, an M2 to M1 ratio of the cells that were there, and it's almost a perfect match. There's a couple of they might switch a couple places, which established, this paper has been cited like a couple thousand times. It turned out that there's a very good correlation between the body's response in this whole M1, M2 paradigm to clinical efficacy and clinical acceptance of the way they're used. So we thought, well, that's pretty good. So then we said, oh, let's see what happens when we take an extracellular matrix and degrade it and expose macrophages to it. So we isolate macrophages from mice every week. We go to the marrow, we flush them, we turn them into a macrophage over the course of 7 days, and they express F480, which is a macrophage marker. We can then expose them to endotoxin and interferon gamma. That makes them a pro-inflammatory phenotype that's marked by this marker, and we can make them an anti-inflammatory phenotype. And then we took that small intestinal submucosa, degraded it, exposed them, and they turned into the M2 phenotype. And then we took matrix from urinary bladder and from skeletal muscle and from spinal cord. So no matter what tissue we isolated matrix from, every single time it pushed these cells to the pro-healing anti-inflammatory phenotype. So this became now pretty central to what we were doing. We were thinking, this is one of the main reasons we're getting good outcomes when we take a matrix that is free of cells and degrades and is put into the sites like the patients with the esophagus because it diminished the scarring and it promoted skeletal muscle formation. And so I'm gonna see where we're going here, okay. So how does this work with stem cell therapy? Because there's a huge amount of work going on in putting stem cells into areas like muscle. And so if we take matrix degradation products and expose muscle precursor cells to just the matrix alone, we can turn them into skeletal muscle cells. If we take macrophages and turn them into a pro-inflammatory phenotype and collect the media and expose those same muscle stem cells to them, we then can cause recruitment and proliferation of the muscle stem cell component. And then if we turn them into the M2 macrophages, we can now cause differentiation of the muscle precursor cells. And there's plenty of published studies on this. I want to get to one more thing before I close up on you. This is how important your physical therapy is. Because applying these basic science principles to the patient confirms what we're doing in the basic science or vice versa. The basic science is confirming that what you do makes a lot of sense. Because we just showed you that if you expose extracellular matrix to, it turns the macrophages into an M2 anti-inflammatory pro-healing phenotype. If you expose these cells to strain, just like you do with physical therapy, with no exposure to SIS, just the mechanical properties alone can turn macrophages into a pro-healing phenotype. So it's more than just conditioning the muscles. you're actually creating an environment in which you're promoting differentiation, healing, and minimizing scarring with physical therapy. And so if you're looking for science to back up what you're doing, you got it. Last thing I want to talk to you about is, so what is it in these extracellular matrices that is causing these effects? Because it's one thing to say, okay, we see it all the time, we now are showing that it happens at the cellular level, but what signaling molecules are present? So this diagram was made by a guy in my lab, very bright young assistant professor named George Hussey, who was a postdoc with me. And this is a diagram of the extracellular matrix. There's all sorts of molecules. There's over 1,000 different proteins within the extracellular matrix. So most of it's collagen or some type of collagen, but there's a lot of other things there as well. And so when a cell comes in contact with these extracellular matrices, one thing it's going to see what's ever on the surface. So there's growth factors that are getting released. There's certain ligands that are there. There's cytokines that are getting released. And so that's one thing that can certainly influence the phenotype. There's collagen, glycosaminoglycans. There's cryptic peptides. Mother Nature is just fantastic in the way that she's designed our tissues. When you get degradation of the extracellular matrix that's within our own body after injury, the enzymes that are released by the inflammatory cells start to clip the proteins that are there at certain spots, like with certain proteases that clip at certain amino acid sites and so forth. And they actually create new molecules that don't exist until that event occurs. These new molecules now become active, and they do things like recruit stem cells. They cause new blood vessels to form. They create antimicrobial peptides naturally occurring that occur only at the time of injury. So you don't need them otherwise. And this is all embedded within the matrix. And these same things happen when you take a biologic scaffold composed of extracellular matrix and put it at a wound site. Now, if we'd have thought of this ahead of time, when we were designing these, I'd have thought, okay, we're pretty smart, this is really cool, it works. But we didn't think of that at the time. We were lucky. And we're finding out that it happens. But most recently, about 4 years ago, another graduate student or a postdoc named Luai Hulahile asked the question, are there embedded nanovesicles within the matrix like there is in fluids? And this is Luai. And what we were able to find is that these nanovesicles, which are about 100 to 200 nanometers in size, are embedded tightly within the extracellular matrix of every species, every tissue that you have. These things they're so small and so tightly protected by the collagen that's there that they survive the decellularization process because they have a lipid capsule around them. And what are nanovesicles? How many of here have heard of exosomes? Okay, so a fair number of you. If you would isolate, do a search for exosomes in the past 10 years alone, you'll find over 3,000 published papers on exosomes. Every single one of those papers describes these types of vesicles within a fluid: blood, central nervous system fluid, CSF, urine, breast milk, tears, you name it. They're always in a fluid environment. And so what Luai and I did was say, are they also present within tissues? And what did they do? Exosomes are loaded with molecules that regulate things like response to injury, angiogenesis, a whole bunch of different physiologic events. They have survival signaling molecules and so forth. They're always found in body. And so when we took the extracellular matrix, dried it, turned it into a powder, and then we turned it into a liquid, and then we could centrifuge it, ultracentrifuge it, and do some chromatography, we could isolate these guys. And we published the first paper in 2016 and showed that in the laboratory-made extracellular matrix from pig dermis, urinary bladder, and small intestine, we found them. And then in the commercial products that had now been used in thousands and thousands of patients, the same extracellular vesicles were present. And we thought, well, that's pretty cool. And so what do they look like? So they've all got a lipid surface, and they've all got cargo within their lumen. And this cargo consists of proteins, microRNAs, and other things that regulate cell behavior. And so we then said, we anticipated that when we tried to publish this, people would say, oh, those are just exosomes that are trapped within the matrix, or they're pieces of cells that got broken up when you decellularized. So we took pure cell populations in culture, and we grew them, and then what they would do is secrete matrix-bound nanovesicles into the matrix that they deposited on the bottom of the Petri dish, and that they would secrete exosomes into the lumen. And so we could now isolate the three different populations, the exosomes, the MBV, and the cells themselves. And then working with Valerian Kagan, who's a lipid guy at the University of Pittsburgh, what we could show is we analyzed the membrane. Each of the three different types of vesicles had completely, and no question about it, distinct composition to the way that they were packaged. And that in itself is pretty interesting, because what it says is, okay, these guys just don't bud off of the cells. The cells package them within, and they know if they're going to secrete it into the liquid interface or if they're going to secrete it into the matrix. And so there's a signature for each of these three different types. And if we look at the microRNAs that are in them, and you do what's called a principal component analysis, you can show, we took these from humans. The MBV, the liquid phase, and the 3T3 cell, when we compared them, showed that they are distinctly, no question about it, different. So not only are the packages different, the wrappings different, the contents are different as well. So what that tells you is that cells within our body, within every tissue, specifically put information into these MBV that are meant to only be released when the matrix turns over and then affect the cells that infiltrate. And all of the signals, we just got done doing extensive RNA-seq on these, all of the signals that are in these MBV are related to wound healing. They're all constructive. They modulate phenotype. They promote organized collagen deposition. If we take the MBV alone, throw away the extracellular matrix, we can get the same results from the matrix that we do with the MBV. So now think about the implications of this. These are nano-sized vesicles. If we want to look at stem cells, if we take urinary bladder matrix and digest it and expose human neural stem cells to the degraded matrix, we cause differentiation of the human stem cells. If we do the same thing with just the MBV, in half the time, we get the same sort of differentiation. So these things, when they're released, think of the two things I just showed you. They modulate the immune system, and they cause stem cells to differentiate, and they're embedded within our matrix. So they're probably one of the key events, the key reasons that we are able to elicit such dramatic biologic effects by taking extracellular matrix and putting it into a human patient. Now, what's even more interesting is that these are porcine-derived MBV. Porcine signals are causing these events in humans. If we'd have tried to get this through the FDA 20 years ago, we'd still be trying to treat the same patient. So my final comment is, think about what you do and all of the things that you put into patients. Whenever you put them in, whether it's artificial hip, whether it's a plate, bone, or a nail, whatever, you expect either there to be one of or more of these things to happen. You're going to get a foreign body reaction. You're going to get fibrous tissue deposited. You're going to end up, the patient's going to end up living with some sort of low-grade chronic inflammation, which is okay. You know, that's what the foreign body response is. Now, if you take the MBV alone, this is polypropylene, a non-degradable material, not unlike the materials you use. You use proline suture material. And everything that's red is a pro-inflammatory cell. These are the fibers. That's what you expect to see. If you take MBV and coat that same material with it, you can go from this type of reaction, which is normal and accepted and present in all the patients, to this type of reaction. where you've got barely a single cell layer of inflammatory cells around it, and yet you've got all the benefits of the material that's there. You haven't changed the physical strength, you've just diminished the scar plate that occurs and the type of undesirable but livable type of tissue response that we've come to expect. So the applications of this are really good. So we're getting smaller and smaller. We started out with the extracellular matrix, went to the different forms of it, and now we're working with these nano-sized vesicles, showing that it's there. So thank you very much. I hope I didn't bore you too much with the science behind this, but I want you to understand that it's an entirely different way of thinking how you affect your patient's healing following whatever you do to them. Thank you.